clinical education and marketing leader of MedSearch Solutions. It's a real pleasure to welcome you all to tonight's MedSearch Solutions webinar. At MSS, our mission has always been clear: empowering health and impacting lives. We continuously seek innovative solutions that help healthcare professionals save lives, especially in the most critical and high risk moments in the ICU and the operating room. As we all know, the first pass failure during intubation significantly increases the ICU mortality. The clinicians often face major challenges such as low visibility, high failure rates on first attempt, and also the difficulty managing difficult airways. So each failed attempt increases the risk of cardiac arrest, hypoxia, other life-threatening conditions and complications. Even the recent research has underlined how intubation complications remain a serious global concern. So, as a company, it's our duty to be part of the solution, to identify and introduce technologies that truly make a difference in patient outcomes. That's why tonight's session is so significant for us. We are proud to present a new advancement in airway management, the Total Control Introducer, a breakthrough device designed to help the clinicians secure the airway the first time, every time. The TCI, the Total Control Introducer, combines flexibility, precision, intuitive control, addressing the geometric and anatomical challenges of airway management. We are also proud to announce that this product is now available in Saudi Arabia and has received full approval from the Saudi FDA. This is reinforcing our ongoing commitment to patient safety and innovation in the region. And now it's my pleasure and honor to introduce our distinguished speaker, Professor Cam Norris. He's assistant professor in anesthesiology at the University of Utah. Dr. Norris has a special interest in airway management, liver transplantation, and resident education. He earned his medical degree from Oregon Health and Science University School of Medicine and completed his anesthesiology residency at the University of Utah, where he currently resides and practices. Professor Norris brings a wealth of clinical experience and a passion for advancing airway management practices. Tonight, he will share valuable insights into the science, evolution, practical application of the TCI, the Total Control Introducer, and how it can transform the way clinicians approach the most challenging intubations. So thank you all for joining us tonight. And now please join me in welcoming Professor Cam Norris. Prof, ready?
Thank you so much for that wonderful introduction. I'm Cam Norris and coming to you from Salt Lake City, Utah. So good evening, everybody, although it's 10:30 a.m. in the morning here. So good morning to anybody in our time zone. So today I do want to talk to you about the Total Control Introducer, and that's going to be the main point of this topic. But I want to tell you about the device, but also why we think it can really help you in the operating room, in the ICU, and in the emergency department. And really, this is a solution that we think will help us in the modern era when we're talking about airway, as we move from the direct laryngoscopy era into the video laryngoscopy era. The question will be, how can we continue to improve first pass success? And we think that the answer is the Total Control Introducer. So without further ado, let's talk about airway for the modern era. So I do not have any disclosures. I want to talk about intubation as a system. So really there are three key components. There's going to be your visualization equipment. So that will be whether you're using direct or video laryngoscopy, but a way to visualize the trachea. In addition, you also have a way to access the trachea. Typically, we can use a malleable stylet, a bougie, a fiber optic, And then we'll talk about how the total control introducer fits into this piece. And then, of course, there's you, the operator. And it's important to keep these three systems in balance, these three components. Another key concept that I want you to take away from this talk is to really think deeply about airway geometry. So this is an image from which represents Greenland's serpentine theory of airway geometry. And this is a sagittal MRI of the airway. And what we see here is there are two key curves. So there is the primary curve, which is the curve around the back of the tongue into the posterior oral pharynx. And anybody who is intubated in airway is very familiar with this curve because you have to deal with it no matter what every time there's an airway. What not everybody recognizes, though, that once you pass through the vocal cords, there's a secondary curve, an inflection point, where the trachea actually dives downward. And this can complicate some difficult intubations. And the total control introducer is developed to solve this secondary curve. And we'll dive into that in more detail. But first, let's talk about direct laryngoscopy. So visualization for DL is about line of sight. You have to take this serpentine geometry and flatten it out and make it straight, make it linear. So this is all about changing the geometry to obtain the airway. And then, of course, when we access the trachea, we also use linear devices. You may be more familiar with this traditional explanation of airway geometry where there are multiple airway axes that we have to align to develop that line of sight. But ultimately, at the end of the day, DL is all about visualizing the trachea with your own eyes. Video laryngoscopy takes a different approach. So instead of changing the airway geometry, we accept the airway geometry as it is, and we use a device that fits that primary curve and looks around it. So here's an example of a hyperangulated videoscope where the curvature is meant to fit the primary curve and then look around and visualize the trachea. And so we start to develop this system where we have visualization and tracheal access as two different components of intubation. And for direct laryngoscopy, it's all about changing that curvilinear or that serpentine geometry into linear geometry and using linear devices to access the trachea. But with VL, especially the hyperangulated blade, we accept that curve as it is and we use matching tracheal access equipment. Let's talk for a brief moment about direct versus video laryngoscopy. This fits into the talk importantly because we think the future will be more about video laryngoscopy than it even is currently. So just to review some literature you may already be familiar with, video laryngoscopy has been shown to have higher first pass success rates compared to direct laryngoscopy. And this is a study from the New England Journal of Medicine, I believe in 2023. This trial was stopped for efficacy. It compared direct laryngoscopy versus video laryngoscopy in critically ill adults. And we see here that video laryngoscopy had about a 15-point better success rate for first pass intubations. And as we've already talked about, first pass intubations are critical because any missed intubation in a patient who is critically ill may increase their morbidity and mortality. So we see here that video laryngoscopy is superior to direct laryngoscopy in this sense. So this trial I just showed you is this Precker trial, and here are the numbers directly. So for direct laryngoscopy, the first pass success rate was 71%. For video laryngoscopy, it was 85%. So just about a 14-point advantage for video. There's also this study in the Journal of Anesthesiology, also in 2023, but instead of using the ED and ICU as the intubating population, this was done in all comers in the operating room. And what we see here is that direct laryngoscopy first pass success rate was 82%, but that increased to 94% with video. And so we see that video has this advantage in first pass success, and this is why we think it will be a big part of our future. What's key to recognize, though, is that the reason these two systems fail are different. So for direct laryngoscopy, what we see is that the reason direct laryngoscopy fails is because it has a problem with visualizing the trachea most often. So in this study, 71% of the time, DL failed because of a problem with visualization. And when we go to video laryngoscopy, we see that visualization isn't the common culprit for why VL fails. Now, of course, there are fewer failures overall in this VL group, but the reason that VL fails is not because you can't visualize the trachea, it's because you can't access it. And now this is the new question for the modern era. How do we fix this problem of tracheal access? So just going back to our system here, there's you, the operator, and we have two ways to visualize the glottis. We have direct laryngoscopy, and this is just a note that in addition to having a lower first pass success rate, it also takes more training to create an expert with direct laryngoscopy. And some research shows between 150 and 250 intubations are required before you become competent. With video laryngoscopy, this might be as low as 5 to 10 intubations. So in addition to having higher first pass success rate, there's also a lower training barrier. And then we'll start to talk about tracheal access here too. Before we do, I want to make one note about video laryngoscopy, and I want to talk about the difference between the standard geometry video laryngoscopy blade, which is like a Mac 3.5, for example, versus the hyperangulated blade. So this is going to be an example of the standard geometry blade. You'll recognize the shape. It looks like a Mac blade. And what we see here is that this does have a video component for you to look indirectly. And that video has a field of view of about 15 to 20 degrees when you are looking around that primary curve at the glottis. And so this can have the advantage of being able to use as to intubate directly as if it's a direct laryngoscopy only, but you can also use the video to assist you as well. And the question is, what happens when you're using this blade, but you have an anterior glottis? And maybe there's a consideration that this low field of view may not be able to help you visualize the trachea the way you need to. And that's where this hyperangulated blade comes in. So you can see that the shape of this blade is quite a bit more angulated, which is where it gets its name. And the advantage here is that the field of view is much wider, 60 degrees. And so even if you have an anterior glottis, you should be able to visualize it. And so just developing this process, of course, with direct laryngoscopy, again, the tracheal access geometry is linear and would require a linear tracheal access device. With the standard VL that we just talked about, we have this semi-serpentine anatomy. So perhaps we don't manipulate the anatomy quite as much and it remains somewhat curved. But with VL, we keep that anatomy exactly as it is, with the hyperangulated blade, that is. Now, this is a study that compared the hyperangulated blade versus Mac video blade. And what we see here is that in this graph on this side, on the x-axis, we have hyperangulated video here, Mac video here, and then POGO means percentage of glottic opening. So basically, how good was the view? What percentage of the glottic opening was visualized? And we see here that with the hyperangulated blade, this is tilted towards the top, such that most of the time you can see the entire glottis. And with Mac video, even though the Mac video blade would be superior, we think, to direct laryngoscopy alone, this Mac video blade, it's less certain that you'll get a perfect view. And then over here, this shows that intubation is quicker with the hyperangulated blade. So we think that not only is video laryngoscopy the future, but specifically this hyperangulated blade seems to be the best tool we have available, the state of the art. So now this brings us to tracheal access. So we said earlier that when VL fails, usually the problem is not a problem of visualization, it's a problem of tracheal access. It's that situation where you can see the cords, but you just can't quite intubate the trachea. And so the question is, how do we solve this problem? Traditionally, when we use a hyperangulated video blade, we use a rigid stylet. And this generally works well in most cases. So this rigid stylet is meant to match the primary curve, just like your hyperangulated blade, but the shape cannot be changed. And so although this solves the primary curve, it does nothing to do with, it cannot solve any issues with this inflection point or the secondary curve, especially if that airway is anterior. So what's the solution to this? Well, a few years ago, some folks here developed this idea of the combined technique using a fiber optic in addition to video laryngoscopy. And with this fiber optic, they didn't even plug it in and use the camera on the fiber optic. They really just use it as a dynamic stylet where the tip can be articulated to fit into, to guide itself into the trachea. And what they found is that for primary difficult airways, they had a higher first pass success rate, decreased time to intubation, decreased airway injury, and they used fewer alternative rescue devices. And you may be familiar with this technique. This is what it looks like. You have one operator holding your video laryngoscope, and then you have another operator using the fiber optic. And this has some advantages. For example, if you can't see the glottis at all, you can convert to using the fiber optic only and using the video on there. But if you can visualize the glottis with your hyperangulated video blade, then you can simply use this as a dynamic stylet. But what if you were alone, or what if you didn't have two people to help you intubate this patient? So this is where the TCI comes in. This is an image of the total controlled introducer. So the components of the total controlled introducer are this flexible shaft, much like a bougie. It too has a hyperangulated tip to match that primary curve. And then it has a handle where when you pull this trigger, the tip of the TCI will flatten out. And so you have total control of how angulated the tip is. Once you've placed this in the trachea, this handle can be removed, and you can use it as a typical bougie to slide your tube over into the trachea. And so one advantage of the total control introducer is that you can essentially perform this combined technique, but you can do so as a single operator. So dynamic introducers, that I would include in that both the fiber optic and the TCI. They have a steerable tip. They can do anterior and posterior articulation. They can deal with that primary curve. They can inflect at the inflection point, and they can deal with that secondary curve as well. And the whole point is that we're just conforming to the geometry of the airway. And I'll show you a video of how this works here on the next slide. So this is a mannequin sagittal section, and you can see our video blade is already in place, and then you'll see our total control introducer used to intubate the trachea. So this is placed into the trachea, and the tube just slides right over. And if we slow this down a little bit, what you can see is that the operator has pulled the trigger and has made the total control introducer more linear. And once they are in the field of view of the camera, they release the tip so that it becomes more hyperangulated. They enter the trachea. And then at this point, you can see that the tip is about to contact the anterior trachea, but the operator will pull the trigger again so that the tip is now inflecting and going down, dealing with that secondary curve. And then it's gently introduced into the trachea. And so to deal with this serpentine geometry, the TCI essentially works like a snake. These are some use patterns of the TCI at our institution. So we looked at over 20,000 consecutive intubations. We gathered the times that the TCI was used, and just we wanted to see how people at our institution were using it. So most often it's used for anticipated difficult airway. And even in those anticipated difficult airways, we see a really high first pass success rate. Novice users have a high first pass success rate as well. These are probably used in easier airways, but training resident on the device, but they seem to figure it out pretty quickly. We use it fairly often in unstable C-spines. It's occasionally used in double lumen tubes. I personally have used it quite a bit for nasal intubations, and it makes nasal intubations, I think, quite smooth. And then we see too that it can be used in cases of glottic edema, maybe where the trachea can be visualized, but the path to the trachea is very narrow, and you need a smaller device to get there. Just reviewing some other data about how dynamic stylettes different from the traditional static stylettes. From this paper, what we see is that not only was the first pass success much higher with the use of a dynamic stylet, but in addition, the trauma to the trachea was lower. So we think that with the inflection that the dynamic stylet can do, the TCI can do, inflecting down the trachea, that secondary curve, it's less likely to rub against the anterior trachea and cause trauma. And so going back to our concept here of the operator, the visualization equipment, and the tracheal access equipment, we talked about how DL has a lower first pass success rate and also has a high number of intubations required to become proficient. VL has a higher first pass success rate and is also easier to learn. And then now with tracheal access, we have the traditional rigid stylet used with a hyperangulated blade. But this may too require a number of intubations to become proficient with, whereas some of our data suggests that even after a couple of intubations, novice users become proficient at using the total controlled introducer. So we really think that this is the best in-class intubation system. We have our indirect visualization with a hyperangulated video blade. We're keeping the anatomy, that serpentine anatomy, the same, and just using equipment that matches it. And then when we use a dynamic tracheal access device like the total controlled introducer, we can also deal with that anatomy as well. And so this creates harmony in our intubation system. Now, one thing that I'll leave you with here before we open it up to questions is oftentimes a question there is vomit in the airway. Isn't it true that I have to use direct laryngoscopy because when you use video laryngoscopy, you'll get blood or vomit on the camera and won't be able to see? And I just wanted to make you aware, if you're not already, that there is actually a system to deal with this, such that you can use video laryngoscopy and the TCI in a contaminated airway. So this technique is called the SALAD technique, which stands for suction-assisted laryngoscopy and airway decontamination. I'll just show you this video here about how it works. So this is the SALAD technique. And I'll note here that in this example, they're using a hyperangulated blade, and they're also using what's called a Ducanto suction catheter. And that's a suction catheter that's shaped like the primary curve. It's different than a Yankauer. The Yankauer is more linear, and this is curved. So the process here is really just to start to visualize where the contamination is and keep that suction in front of your video laryngoscope to suction the airway. And in this case, this would be an example of like a GI bleed. So they'll clear the airway here, gain visualization of the trachea, and then they'll move the suction device over to the other side of the laryngoscope and put it into the esophagus. And so now we have continuous suction here while we're visualizing the trachea. And here you'll see a dynamic introducer used to intubate the trachea. So the point of this video is that I just often get this question that whether or not VL can be used for contaminated airway, and I think the answer is yes. And I personally have actually used a hyperangulated blade and the total controlled introducer in a contaminated airway with success. So I'll pause there. I have more that I can share with you, but first I just want to open it up to any questions that you have, and I just want to thank you very much for your time.
Thank you, Dr. Norris, for this helpful presentation. Very informative. You can write your questions in the chat box if you want. We already have one question, Dr. Kam, if you want.
Oh, yeah. So I see in the chat box here, could you provide the references for the number of intubations for your visualization intubation proficiency slide? Yes, well, we can send that out afterwards. And Ivan, could you just clarify, is this the those two major studies that I showed? Are you referring to the two major studies I showed comparing direct to video laryngoscopy? I'll let Ivan respond in the chat here. But if there are any other questions, I would be more than happy to answer them. And as we're doing that, I'll also just show you kind of this concept, the way that you can, another way to think about the airway geometry, visualization, and tracheal access equipment. So here we have in this row, visualization geometry. In this row, tracheal access equipment. And this is kind of what we see as the progression through time. So in the DL era, we have, of course, direct laryngoscopy, where we create linear geometry and use those linear tracheal access devices to access the trachea. And then the advancement in the early 2000s was the introduction of video laryngoscopy with indirect visualization and the rigid stylet, which solves that primary curve problem. And now, because there are a small number of remaining patients who cannot be intubated with this static stylet alone, we now give you the hyperangulated blade with our total controlled introducer. Okay, Ivan, I do see you're talking about the proficiency and how many intubations it takes to become proficient with VL. And yes, we'll get those references to you. We'll send them out in an email later. As we are waiting for any more questions to come in, I'll just come back to this video again and just show you again, if you miss it the first time, how the device works. And it looks like Salma is asking, what's the success rate of having it of using the TCI for the first time with a hyperangulated blade, and can we please have the numbers? So what I can show you, so we can send out that again, at least in our use patterns, what we see if we break this down by different type of indication. Here are those numbers, Salma. So for anticipated difficult airway, so patients who may have we think a lower success rate than what we see here with the TCI. For anticipated difficult airway patients, the first pass success was 88.9%, so 112 of 126 intubated on the first pass. With novice users, we see that in a relatively easy airway, but with a novice user, we see a high success rate of 93%. And then if you were to combine all of these ends together, you would get, I would say it would be our overall success rate, which I would anticipate to be in the high 80s or low 90s. Salma, does that answer your question? Great. So it looks like that answers the question for the numbers. And then Salma's also asking how many trials we have to use. I think maybe what you mean is how many times do I have to use the device to become proficient? Is that correct? If that's your question, what I would say from personal experience is that it at least takes one time, of course. There is some uh, learning to be done with the device for how to open the handle and remove the handle efficiently. My personal experience is that once you've used the device 2 or 3 times, you've really got the hang of it. It is quite simple once you understand how much pressure to apply to manipulate the tip and to remove the handle. There's another question here from Ivan. Do you have personal experience with the Store's D blade versus the GlideScope hyperangulated blade? So I actually don't have personal experience with the Store's D blade, but now that you bring it up, I'm excited to go take a look at it. And if you have any experience with it, we'd love to hear your experience in the chat box. And there's a question from Yad who says, do you use the TCI in the first trial of an intubation or after facing difficulties? For example, if you find out if the um, airway is anterior. What we would say is that the rigid stylet is the hyperangulated blade plus the rigid stylet is useful for most intubations, maybe even up to 95%. And so a typical way that this can be used is you can do your first trial with a rigid stylet, and if you find that the airway is anterior, you rescue with the um, TCI. So that would be a standard way to use it. I would also say that the way that I personally use this device is that if I have an airway that is in a critically ill patient, I know it's going to be difficult or the stakes are high. For example, if I think that there's glottic edema, if I think I'll only have one shot at intubating this patient before I have to move on to other things like an emergency cricothyrotomy, my personal approach is to use the hyperangulated video blade with the TCI because I feel like if I were to encounter difficulty with the airway, I may not even realize it. Like I'm just using my best tool first for a high stakes scenario. So that's my personal practice. And when the stakes are high, I use the TCI. In general, if the patient is not critically ill or I don't anticipate a difficult airway, I'll use the rigid stylet. And if I find that the airway is anterior, then I will rescue with the TCI. And then we have a question here. Do you need a special endotracheal tube with the TCI? And the answer is no. You can use a standard endotracheal tube. It can be used with a standard ET tube or a Parker ET tube. I will say it can be a little difficult to intubate with a long nasal tube or with a double lumen tube. The reason being that sometimes if the ET tube is extra lengthy, as in some nasal tubes, or a double lumen tube, then the length of the TCI is just barely enough to be able to grab the end of the stylet once you place it into the airway. But I have used it with success. But generally speaking, no, you can just use whatever regular endotracheal tube you're already using. These are great questions, guys. Thank you for your questions. I think I can show you here too some other data. This is something we presented at the Society of Airway Management last um, last September, about a year ago. And so we investigated the use of the TCI specifically as a rescue device. So, for example, this is what we use the here we call it the steerable single-handed introducer, but this is the TCI. We used it after either failed DL, failed VL, failed VL with 2 attempts, both failed VL and DL, etc. And then this is the combined all rescue attempt. And what we find is that after failed DL on our first attempt with the TCI, after a failed DL, we had an 87% success rate for a rescue. And then the second pass, those last 3 intubations that we missed, with a second pass with the TCI, we were able to secure the airway. And this pattern is pretty consistent. So essentially a high 80s. We have a success rate with first pass with the TCI in the high 80s when using it as a rescue device after we've already failed an intubation. There is a question from Hazim who says, do you have any idea about video stylet intubation, or are you using it in your institution? So I do understand there's development of some stylets that may have video capabilities on the end of the stylet itself, and that would be pretty similar, I think, to using a fiber optic bronchoscope. What I will say is that we do use fiber optic bronchoscopy here, and I have used combined video laryngoscopy with the fiber optic bronchoscope. And I think that it can be a very useful technique and something that I always keep in mind. I find it to be particularly useful if we place the video laryngoscope and find that we actually have a poor view of the glottis. So it doesn't happen that often, but it can happen with the hyperangulated video blade with any type of tracheal visualization equipment that you may not perfectly visualize the glottis, in which case we'll keep the video blade in place and then advance the fiber optic bronchoscope, but use the camera on the end of it to guide ourselves into the airway. There's another question. Is there or are there any other limitations for the equipment functioning rather than the tube length? Not that I can think of off the top of my head. I would say sometimes with a double lumen tube, depending on the size of the double lumen tube, the size of the one of those internal lumen might be quite tight, like it might fit quite tightly over the TCI, which is true of any bougie, of course, or if you're using a very small endotracheal tube. For example, I don't believe that you could use a 4.0 endotracheal tube with the TCI. I think the minimum is a 5.0, but we'll have to double check that. So that's one of the only other limitations. Otherwise, it seems to work quite smoothly. And then Salma asks, is it multiple use or is it use once and throw away? So this device is a single use device. Thank you for asking.
Doctor, please check the last questions in the question and answers section.
Sorry, I might have missed that, but it sounds like we'll have time for just a few more questions.
Yes, what is the smallest size ETT that can be loaded to TCI?
I believe okay. I think it's a 6.0 endotracheal tube would be the smallest. So there would be a limitation there if you were using this in the pediatric setting. This device would probably be better used in the adult population. There's another question here as well. How does the endotracheal tube pass through the handle once it's on is one question. And then the other question is, when is the TCI used? Is there no need for a stylet? So I will show you. we'll go back to this diagram of the TCI right here. So I wish I had an animation for this, but what I can tell you is that this handle is removable. And so you basically preload the endotracheal tube on the back here. That's at least how I use it. You could also slide it over after you've gained tracheal access. But I preload the tube here. Obviously, I pull the trigger to articulate the tip, and then you can just see that there is a triangular shaped piece just above the stylet. And as you're holding it with your hand, you can use your thumb to push that forward, to push this triangular piece forward. And it essentially opens up the handle, and the handle can just come right off. Um, so this handle obviously is in place so that you can articulate the tip, but once you have tracheal access with one hand, the hand that you're already holding it with, you can just use the thumb to essentially pop the handle off. And then it just becomes a stylet only or a bougie only. And so in that, I guess that leads to your second question, and which would be, do you have to use a stylet? So I would say there is no need for a endotracheal tube stylet because you're going to use the TCI to guide the endotracheal tube into the trachea. Well, I know our time is winding down. I just want to say here in the final minutes that I want to really thank you all for coming today. I love talking about this topic, about both video laryngoscopy and tracheal access. And we're really excited, obviously, to share the TCI with you. And we hope that it becomes a helpful part of your clinical practice.
Thank you, Dr. Norris.
Thank you.